Welcome everyone to this new Straub webinar. Today we are here to introduce a very nice topic. I'm really excited and getting emotional for this topic. Actually, I think it's one of the hottest we have in the endovascular world in the last years. We will talk about percutaneous deep foot vein arterialization. And actually, we will go through this team, through this indication, with a team of super experts, actually with a team of stars, which I will introduce you to later. Let's start and give me the chance to give you a couple of advices to best use the platform. We are using today GoToWebinar, so please feel free to change your setup languages here in the icon, or also to enlarge the webcam you like in your video. You can also download some contents we made available for you here in the documents bar. And also, and most important of all, please feel free to use the question windows to ask, to comments, and to tell us something about you. We will really want to hear you close to us during this webinar. So use the question bar to make questions, comments, or also just to tell us your name, where you are connecting from, and if, for example, you already did some deep foot vein arterialization in your career. Now, let's start immediately. I don't want to waste not even a single second. Let's start from the moderator of this session, from Policlinico Abano Terme, the chief of the radiology department. We have connected Dr. Marco Manzi. Hello, Dr. Manzi, how are you?
Hello, guys. Can you hear me?
Yeah, loud and clear.
Okay, good afternoon to everybody. Thank you for the kind invitation, and I'm very pleased and happy to share with you this afternoon. And I am completely sure that the session will be amazing, and we have some nice people sharing with us this session. So I prepared a small presentation just to introduce the topic of today, and I will let, of course, Bruno and August to learn to teach us how can we do in the best way, and how can we choose the best patient for this important and alternative technique with CLI patients. So
yeah, Marco, before we start, let me introduce also our other guests from Bilbao, from the University Hospital Cruces in Bilbao, from the vascular surgery. We have Dr. August Isa. Dr. Isa, hello, how are you today?
Ciao guys, how are you doing? Fine, thank you.
Fine, thank you. Thank you so much. And actually, also from Pedersoli Hospital, diabetologist and foot surgeon, Dr. Cristian Nicoletti. How are you, Dr. Nicoletti?
Fine, thanks. Thank you for this opportunity, and congratulations, Bruno, for the organization of this top-class webinar.
Yeah, exactly. And so last but for sure not least, from Peschiera del Garta, again, Pedersoli Hospital, the organizer of this event, is a pleasure for me to introduce you to Dr. Bruno Migliara. Hello, Dr. Bruno, how are you?
Fine. Hi, guys. Good afternoon, and to everyone. And I hope this section, this webinar, can be interesting, can be helpful for the daily clinical practice. And of course, first of all, I have to thank Straub Medical and Sergio for hosting us and for supporting this webinar. I'm really proud to have Marco Manzi as a moderator and our guest star in this webinar. And I have finally to thank my co-speaker August Isa and Cristian Nicoletti for sharing their experience. Now we are ready, I think, and then let's start with the introduction by Marco.
Next one, please.
Okay.
Next one. This is my disclosure. Okay, just I will be as fast as possible. Everybody of us is knowing very well the picture and the dimension of the problem we have to manage every day in our cath labs and in our foot and ankle department. For sure, in the last years, especially in the last 10 years, we had an explosion, epidemiologically speaking, of critical limb-threatening ischemia. And as you can see in this slide, the prevalence in the next 10 days is going to be really higher and higher, reaching 43%. In some countries, together with the diabetes, like in the Gulf countries, I mean, in the area of Dubai and Egypt and Saudi Arabia, we still have 43% prevalence in diabetes mellitus. So next slide, please. We know that we can treat a lot of patients. Fortunately, we can treat the most of patients with PAD. Can you click another time, please, Sergio? But there are some patients who they present really a severe condition, and normally those patients we define patient with a desertic foot or the desert foot. They are in a population of diabetic patient, dialyzed patient with an history of prolonged corticosteroid therapy, and they have a very bad, next slide please, very bad vascular situation. Of course, in the literature, we know that if we do not treat this patient, we have a very bad prognostic destiny for this patient. We have a very high percentage of death, a very high percentage of major amputation, and a very high percentage of non-healing wounds with all the possibility of infection we have. Next slide, please. So next slide. This is about the cost, who is very, very high in this patient, and the clinical outcome is very, very bad in the patient with the association of diabetes and the peripheral artery disease. Next slide, please. So in 2018, Roberto Ferraresi, our friends, published this fantastic paper about the different populations. So we realized finally we have two kinds of big population of patients, and one attempt to define these two populations is this paper, and we have the bad patient who are defined by big artery disease, and in this patient we can be really aggressive, achieving very nice acute result with revascularization, extreme revascularization, and it's related with this nice acute outcome, a good, a fantastic, probably clinical outcome. And then we have a population we define SAD, small artery disease, population of diabetic with dialyzed and prolonged corticosteroid therapy. Normally, in this kind of population, the amount of failure, technical failure with a normal endovascular revascularization is more than 50% in my center. I don't know in your center, but the percentage is very, very high. Next slide, please. So in the last years, we tried to rescue a very old technique already published 1 century ago, and for this patient with a long history of failures, consecutive failure attempt or revascularization, there is the possibility to create what we call a deep vein fistula arterial in order to achieve the arterialization. And we have basically 3 techniques. The first is a completely open, so surgical technique published by Pramuk Mutirangura from Bangkok. The other one is completely percutaneous, published by Stephen Coombe from Singapore with a dedicated device. And then there is another published technique, the hybrid technique from Roberto Ferraresi. Next slide, please. These are the papers. The oldest is the paper from Mutirangura 2011. The latest is from Ferraresi. Next one. Okay, this is the lymph flow. Next one. I can show you very, very fast 3 cases. This is the first one created with the lymph flow. Next one, please. You can see here the baseline with the desertic foot, the creation of the fistula with the acute result, the check after 45 days and 90 days. Next one. And finally, the clinical outcome with after 5 months, the complete healing after the transmetatarsal amputation. Next one. We can see here the hybrid technique, another very bad situation in the foot, the desertic foot. Next one. The creation after a FEM posterior tibial vein bypass, the creation of the fistula. You can see here a big coil closing a vein to redirect the flow towards the forefoot. Next one. And the healing of this patient with this technique. Again, the last case. And this is the case we performed all together, me, Bruno, Roberto, Steven, during the last click edition, a patient with more than 3 endovascular failure performed by me. Next one. We decided to select this patient for a lymph flow procedure. Next one. This was the acute result after the procedure in the cath lab. In the next weeks, next slide, the patient had completely the pain disappeared in his feet, in his foot. Next slide. We called the patient back and we closed with the coils 2 veins in the foot to redirect to the forefoot, preparing the patient for the transmetatarsal amputation. Next one, please. He had finally, after 6 weeks, a transmetatarsal amputation, and this patient has been called 2 weeks ago, and he has an ambulatory and outpatient appointment when possible. He is living in Calabria, so he's coming back to have a check by me at the end of this month. But by telephone, he told me he is completely healed, still no pain after 13 months. So next slide. I will conclude now that actually with this technique, we have the impression that probably we may have a possibility, one more possibility, one more chance for the no option patient. So those kind of patients who are candidates for a major amputation sooner or later. Of course, we have to standardize the technique. Of course, we have to collect data. Of course, we have to change our mind in the team. So the surgical approach, the follow-up approach, the selection of this patient in order to offer in the best way this technique. Thank you for the attention. I leave you I leave you as a masters in this technique, actually, with new option, with new techniques, and we are ready to know what we could do for our patient now. Thank you.
Thank you, Marco. Thank you for this very interesting, very precise introduction. It's possible to see my slide on the screen?
Yes, it is.
Okay, perfect. Now, during the first section of this webinar, we try to introduce the anatomical and the physiological most important key point that it needs to keep in mind during the AV reversal flow procedure. About the anatomical key point, of course, we can see well here that in case of in the venous network into the foot, the situation is a little more complex with more vessel than in the arterial network. If in artery we have two main levels, the dorsal and the plantar connected to the tarsal artery, the pedal plantar loop, the tarsal loop. In vein we have 4 different levels. 2 dorsal, superficial and deep, and 2 plantar, superficial and deep. And the most important level are the superficial dorsal, and this level through the medial marginal vein constitutes the great saphenous vein, and the deep plantar. The deep plantar constitutes the posterior tibial vein, as you can see in this venogram. And then based on this, this is the first concept to know well, because based on this anatomical concept, we understand why the best way to obtain the flow in case of totally percutaneous arterialization, to obtain arterial flow into the foot venous network, is the posterior way through the deep plantar level, because of course the other well developed level than the superficial dorsal constitute the great saphenous vein, and of course the great saphenous vein is too far from any artery to be connected percutaneously. Then this is the reason why our connection usually is at the level or the tibioperoneal trunk, or at the proximal level of the peroneal or the posterior tibial artery. Then we arrive with the foot, with the flow into the foot, and we arrive through the deep plantar vein. We have to know the anatomy of the deep plantar vein. The anatomy in the deep plantar system is made from the deep plantar arch. This arch goes from the first to the fourth interosseous space and receive the plantar metatarsal vein, and also is constituted from the deep plantar vein, the medial, but the most important is the lateral deep plantar vein, because this vein connects the deep plantar arch touch with the posterior system at the level of the calcaneus channel. And the calcaneus channel is another very important issue that we have to keep in mind, because at this level, due to the presence of the flexor retinaculum or laciniatum ligament, that is the ligament that goes from the medial malleolus to the calcaneus, and this ligament is a reason of well-known compressive syndrome, atarsal syndrome. Then, based on this compression, for this compression, we understand why the deep plantar level and the deep plantar vein are enlarged and dilated and look like a Venous lake. In some cases, this ligament, the compression due to this ligament is very high and stops the flow into the foot. This is the reason why now in many patients we extend this stent across this ligament. This in order to improve our flow into the foot. When we arrive into the foot, the different 4 levels of vein to the foot are connected through collaterals and above all through perforator. Usually these perforator are avvalvulated, and the most important perforator, well described by Lengua, is the perforator number 6, because this perforator connected the 2 most developed levels, then the deep plantar with the superficial dorsal. And this perforator is located at the first interosseous space, and usually in more than 90% of cases is completely avvalvulated. But when we arrive at this level, the flow into the foot seems to be in a roundabout, without flow into the forefoot. This because the most important way out of our flow is the dorsal main vein of the first 2. This vein, conversely to the perforator vein, has 2 or 3 valves. Then usually we have to navigate this vein to cross this valve, and at the end to devalvulate this, usually with a venoplasty. This in order to obtain a good flow also into the forefoot. Then in conclusion of this anatomical presentation, I think there are, to recap, there are 3 mandatory things to keep in mind. The first one is that usually the way to obtain the flow into the foot in many patients is the posterior way through the deep plantar system. We have to pay attention to the compression at the calcaneus channel, because in many patients this compression can reduce the flow, and then in some patients we have to extend the stent below this ligament. And finally, in every patient we have to know that the way out to obtain the flow into the forefoot is the dorsal main vein of the first 2, and we have to devalvulate this vein to obtain at the first attempt the flow into the forefoot. This about anatomy. Now I give the floor to Augustisa to know the physiological situation when we obtain an AV reversal flow. Thank you.
Okay. So thank you very much, Bruno. I'm really honored to be part of this panel moderated by Marco Manzi, who has been an inspiration for our team since the very first time. So let me just move to our presentation. The first thing that came into my mind when Bruno asked me to talk about physiology of reversal flow was that actually we don't know the exact mechanism of action of vein arterialization. But nevertheless, I'm going to catch you up on what is considered the generally accepted theory. So this is the baseline situation in which you have an occlusion of the arterial flow, which prevents flow to the tissues. But when we perform a DVA, you increase flow in venula, and this is retrogradely transmitted to the capillaries that are filled, and this generates a recruitment effect that increases flow in hibernated collaterals. This will increase direct nutrition of tissue with increase of TCPO2 and stimulates the angiogenesis. And this can be seen in consecutive angiographies following a DVA. And as you can see in this slide, 4 weeks later the procedure, you can see some of this new distribution system. With regards to biological finding, we have seen in animal models, specifically in rats and dogs, that there are evidence of reduced ischemic markers and increase of blood flow following DVA. And this effect is analogous, it has been seen in humans with an improved microcirculation in the target skeletal muscles following DVA. If we have a look at the level of lactate levels, which is an ischemic marker of human tissue, you will see that the curve of lactate decreases over the time following a DVA. And with regards to TCPO2, which is a reliable predictor of wound healing, this is a slide from Stephen Kuhn in one of the patients. You see the TCPO2 increases over the time, and this is the overall series of Stephen Kuhn. And this has also been seen in most of the published series in percutaneous DVA. In all of them, you see an increase on TCPO2. And what is really interesting to mention is that this effect stands over the time, regardless the occlusion of the revascularization by the DVA. And the rationality behind this is what we have already mentioned. When you have your DVA patent, you recruit a new capillary system that will stand the perfusion of the tissue despite the occlusion of the DVA. And all of these concepts were put together by Roberto Ferraresi, who is a leading expert on this field, who states that if arterial blood flow does not reach the venular microcirculation, this is not going to be a DVA, but it's going to be a normal AV fistula, because you will get just flow recirculation without increasing flow the distal perfusion. And this was nicely presented in the Link 2020 with a concept escape from the forest. And as Bruno has already mentioned, the forest is basically the confluence of the superficial dorsal system and the deep plantar system at the level of the perforators. So according with Roberto Ferraresi, there are two basic mechanisms of action, the mechanical one and the biological one. And the mechanical consists on the direct tissue nutrition by reversal flow due to the hydrostatic pressure of the DVA, and this will perform a distal vein recruitment that will provoke a vein failure. And the biological effect is the remodeling of the neoangiogenesis created a new food distribution system. And there are several differences between both effects. And for instance, the mechanical effect has an early effect, whilst the biological hypothesis needs weeks or months to generate this new vascular distribution system. The technical target for the mechanical mechanism is small vein devalvulation and increase in plantar vein network, while for the biological would be vascular remodeling. The target would be Rutherford 4 or 5 limited ulcers for the mechanical hypothesis, and the biological effect will help to heal larger wounds. And the key point is patency, because occlusion would entail a redo on CLTI in the mechanical effect, whilst, as we have already explained, continued perfusion is seen in the biological effect despite occlusion. So in conclusion, we are currently now able to know what is the effect of a DVA and how to perform the AV, and most of the procedures has more than 90% success rate, but we still don't know why does it work and in which sort of patients, these no option patients, this procedure will be indicated. If there's any anatomical distribution that may influence on the outcome, or is there any sort of tissue loss threshold that may prevent a good result. And this actually leads to a certain degree of unpredictability that witness what is still a 30 to 40% amputation rate for this procedure. So in other words, so far nobody can explain why a flawless procedure with focalized flow to the forefoot can end up in a major amputation due to extensive necrosis or sepsis, regardless having a patent revascularization procedure. Thank you very much.
Thank you, August. Guys, there are some questions from the audience. I think there is Lorenzo Patrone, our friends from London, is asking if the patency of the cover stent, so the Viaband deployed below the ligaments in the ankle, as you showed us, Bruno, is quite acceptable. So his question is this a sustainable option to deploy a Viaband below the ankle?
Yeah, I think when I started to place the stent below the ankle across the laciniatum ligament, I was a very lucky man, because I tried in a patient. I recognized I think the fourth time the occluded DVA. And at the end, I placed this stent, but I'm not sure this is a good idea. And this arterialization stay open for 18 months with complete healing of the wound. And then I changed completely my idea, because in many patients I had an occlusion at the ankle level, and I think this is a big problem. And now in every patient I go into the foot with the stent, and the patency improve a lot. Then, of course, now for me it's mandatory to go into the foot with the stent.
Okay, this is a good answer. In our experience, we do not have the Viaband, as you know. So normally that valve in that area is quite difficult to be managed with a high pressure balloon, for example. And as you can remember, exactly in that procedure we performed during the click, we finally succeeded in breaking the valves, I think at 30 atmospheres.
Yes, with a Dorado balloon, I remember.
Yes, 8 millimeters Dorado balloon, 30 atmospheres to achieve finally an incompetence of that valve. Okay, another question. I digited on myself the answer, but is nice to share. This question is how do you redirect the flow to the forefoot after the creation of the fistula from Cesar Quen Ojeda? So my answer is I check after 3-4 weeks, and if there is a Stilling syndrome through collaterals, I deploy some coils.
Yeah.
I don't know if there is another kind of answer or other technique.
By coils, or in some cases, I perform also a surgical ligation of the great saphenous vein at the ankle, because it's quite easy to perform the ligation, but coils are okay.
Then there are another couple of questions from Kinya Matsui. After DVA procedure, HIF level is higher. I don't know the acronyms. HIF. Can I write for you?
Heart failure? No.
HIF, I don't know.
We don't know.
I don't understand. HIF.
The other The other question is extreme venous hypertension. Is it harmful? We should know good level of venous pressure for wound healing. I mean, the swelling process of the foot is constant in every patient. Christian, how is the situation with this patient after this new circulation in the foot?
I will share with you in my presentation later, but the important thing, in my opinion, in this field, for a diabetic foot surgeon after a DVA, is not to be in a hurry, because we have to wait the arterialization to make his work, and so we have to wait, for instance, the necrosis to demarcate, and me and Bruno in the last period decided to treat with a tension-free surgery this patient not before 5 to 6 weeks after the DVA.
Okay.
Okay. An anatomical question. Sorry, because I'm. Can you explain the importance of the dorsal main vein of the first toe?
Okay, the concept is that in case when you arrive with the arterial flow into the deep plantar vein, usually the flow goes retrograde through the superficial plantar system, superficial dorsal system, because the valve are in the right direction, and then this in this case we have the flow stops at this level with a roundabout at this level. Then this is the reason why now we try to navigate the dorsal main vein of the first two, because this is the bigger one, and to open this valve, to obtain at the first attempt a little bit flow also into the forefoot. Then after, for a mechanical process, there is a devalvulation, but I try to navigate in every patient this vein to obtain a little bit flow into the forefoot. And in other cases, the forefoot remain completely empty.
Okay. Another technical question from Enrico Paci, which I say hello. About coils we can use. So to achieve a vein occlusion, which kind of coils? Is it possible to use detachable coils as neuro intervention coils?
No, I use the normal coils, not detachable coils. 5-6 millimeter coils, but the normal from Cook, from Boston, not.
Yes, personally we use the tornado
okay.
coils from Hayri coils.
Yeah. Okay. Yes.
Yeah. Again, is it possible to use Peter Goverde is listen to us? Can you use a super stent to instead of a Viaban, or another question similar was a bare metal stent instead of a Viaban below the ankle, I mean through the ligament area?
I tried to use Viaban, the super stent, but in case of use of super stent, the stent close in 1 month, and I think I tried to study also with IBUS the situation below the ligament, and I think the Viaband is the stent that is able to adapt better than the other to this situation, because is a very complex, and then the flexibility of the Viaband I think is better than the other, but I'm here to open for every possibility.
Okay. There is another technical question about the overlap of stent from Giacomo Isernia between the stent because he is telling us about leaks between the overlapped stents. So the question is, how much do we have to overlap stents in posterior tibial vein?
Okay. Ciao Giacomo, and the problem is that the via band, there are not so many possibility of length. Usually I use the 250 in the proximal portion, and then or the 100 or 150 in the distal portion. Then the overlap change a little bit from one patient to the other one. Usually I try to have an overlap of at least 1 centimeter, but it's very difficult to obtain the right overlap.
Okay. There are the next the most of the next question are clinical, so we wait the clinical evolution. Let's go.
Okay. Now, in this second part of this webinar, my idea, the August idea is to present the other possibility, the technique to obtain an effective arterialization with a standardized technique. Of course, sorry, you can see the slide.
Yes, we can.
Okay, perfect. Okay, then of course, as Marco said before, we can use some different treatment to obtain the AV reversal flow, the open surgery, the hybrid technique, and the totally percutaneous. Today, we are focusing on these two techniques, the Piper technique proposed by me and published in 2018, and the technique proposed by August, the VAST technique. About the Piper technique, the idea started in 2017 after the market relaunch by Philips of this catheter, the Pioneer Plus catheter, and then to use this catheter that is an IVUS guided needle catheter to create the AV connection. Now, the procedure step by step to better explain the technique. Usually we start the procedure with an antegrade ultrasound guided puncture of the common femoral artery, and we place at this level a 6 French sheath because the Pioneer Plus catheter goes on the through the 6 French sheath. We perform the first angio, and these are to evaluate the situation, to decide the best site, the best donor artery, tibioperoneal trunk or the proximal portion of the peroneal or the posterior tibial artery, and then we prepare well this artery. We go with the device into the artery, and this is the typical IVUS view at this level. In the orange circle, we can see the artery, and close to the artery in the yellow circle, the two satellite vein of this tibial artery. Then, rotating a little bit the device, we choose the best side, the best vein to arterialize. We place this vein at 12 o'clock, and then at this moment, we push out the needle from the artery into the vein. We go into the vein with a O14 non-hydrophilic we open this AV connection with a p-DVA, and then we cross all competent valve with different catheter, with different guide wire, usually with a common 18 guide wire, and then until the guide wire arrive into the deep foot venous arch. Based on the previous anatomical key point, previous explained key point, we try in every patient to navigate the perforator number 6 at the first interosseous space, and then with the, in this case, a 6-side catheter and a command 14 guide wire, we cross the competent valve of the dorsal main vein of the first two. At the end, is mandatory to obtain a good devalvulation, and usually into the foot an adequate venoplasty is enough to obtain a devalvulation and to crash all competent valves. We completed our arterialization placing the cover stent along a via band, usually 5 mm in diameter, 250 mm in length, along the tibial vessel to close all collateral and to open all competent valves. And then, as I explained before, usually I go with the stent across the ligament. Then we completed the AV connection, placing at the connective the connection point a coronary cover stent and flaring the vein portion of the stent. This in order to direct downward the flow. This in order to obtain this final result with this is the okay, this is the flow into the foot. We can see also the flow into the dorsal main vein of the first two. In every patient, after 4-6 weeks, we perform another angio, and during this angio to evaluate the situation and eventually to perform a coil embolization or a surgical ligation of collaterals of perforator in order to focalize and above all in order to pressurize our arterial flow into the venous system. This, in order to obtain this final result, a very good distribution of this arterial flow through every vein into the foot, with is very important, we can see in the duplex study, to obtain an effective flow rate into the foot, like in this case, with a flow rate more than 400 milliliter of minute. And now, during the last months, we have started also to use the AV injection of green of Indochina to better evaluate after 6 weeks, 8 weeks, the real distribution of the flow into the foot, and to help Cristian to evaluate the right side where to perform the amputation. Of course, this type of treatment has some complication. The most serious complication is the stagnation syndrome. This stagnation syndrome appears usually during the first 24 hours after arterialization due to the thrombosis of the evacuation system, the evacuation way. Usually, in case of weight gangrene, is a thrombosis due to the infection, but in some cases can be also an iatrogenic thrombosis in case of an embolization of collateral during the first step of the arterialization. And this is a very serious, very distressing situation, because usually the only solution is the major amputation with an arterialization open and well functioning. The other complication, of course, is the thrombosis of our arterialization. In this case, usually we perform a recanalization using Rotarex in order to remove all thrombotic material in order to restore the flow into the foot. Then, in conclusion, the idea of the Piper technique, the advantages of the Piper technique are that, first of all, it's possible to perform all the procedure with only one antegrade 6 branch sheet into the common femoral artery, and then avoiding a distal puncture in a tibial vessel, then in a ischemic and eventually infected area. And second, we have a direct ultrasound view of the vessel, and then we can choose the best vein to arterialize, the best site where to create the arterialization. Two mandatory key points of this technique, standardized technique. The first one, to create the AV fistula, the AV fistula has to be proximal. This in order to improve the flow rate into the foot, and second, to go with the stent across the laciniatum ligament. This in order to improve the patency of our arterialization and then the clinical outcome. Thank you. And now the VAS technique by August. Thank you very much.
Thank you, Bruno. So the venous arterialization simplified technique was described, as Bruno has mentioned, by our group and published last year in the Journal of Endovascular Therapy. We initially used a balloon catheter and a snare, but we rapidly moved to the double snare technique, since it streamlines the whole procedure. So what we basically do is, when you have a failed VDK recanalization attempt, we leave our O14 or O18 wire in place. We progress a 4 or 5 millimeters snare through the wire, and then we gain access at the level of the posterior plantar vein or posterior tibial vein, distally at the ankle, and then through this axis we progress a second snare up to and parallel to the former one. So we will perform an orthogonal view in order to assess what is the position of the vein with regards to the artery. And in this example, the vein is above the artery. You have both the snares overlap, and thereafter we will perform a percutaneous puncture with a 21 gauge needle through both the snares. We pierce both the snares. Thereafter, we will progress the O14 wire. We'll close and withdraw the arterial snare, progress a balloon catheter, close and withdraw the venous snare from the axis at the level of the ankle, break into the vein, and secure the axis with balloon dilatation. These are clinical images of both techniques, the VAS and the VAS double snare, and as you clearly see, the elements are quite nicely visualized. This is a short clinical video. This is the axis of the plantar vein, the wire.
See anything.
I can see. No, I can see.
Okay, so I'm going. This is the venous snare and the arterial snare coming from above. Once they are overlapped, we perform a percutaneous puncture through both the snares, and then we will progress an O14 wire, a soft wire. Here, the wire is located extravascularly. We will retrieve the needle, close and retrieve the venous snare, and we're gonna withdraw as well the arterial snare. So we have a through and through wire from the artery to the vein, and through this through and through wire, we will perform a balloon dilatation. Then we will balloon the plantar and the arch, as mentioned by Bruno, and this is the completion angio with excellent flow to the foot and to the arch. So in the series we published last year in the Journal of Endovascular Therapy, we treated 5 cases with a 75% limb salvage rate 6 months. What are the main advantages of the VAS technique? I would say that the main advantage is the universal availability and the low cost. This is no longer a blind technique, and this overcomes the 20% failure rate of Gandini's technique. The technical difficulty is fairly low if you have a minimal experience in retrograde puncture of distal vessels. And when you are dealing with calcified vessels, the needle penetration power is increased. So the key point with this technique is that you can either perform a distal DVA or a proximal lymph flow-like DVA using really basic off-the-shelf devices. Obviously, this is a less codified technique compared with the people described by Bruno or the lymph flow device, and we still don't have big data with regards to reproducibility, although we already have amazing feedback from different countries around the world. So just let me spend a couple of minutes talking about post-op management, what we talk the chameleons strategy, because as we always say, the good outcome of a DVA has to do with almost everything but the hole itself. So you need to keep, as mentioned, 360 degrees close follow-up with multidisciplinary wound care and selective debridements in case of abscess or wet gangrene. We need to be really patient to face what we call the storm post-DVA, and the storm after DVA is the effect secondary to this AV shunt, which overloads the venous system and produces an ischemic still syndrome on the remaining arterial 3. It seems to be more evident in proximal DVA than in distal DVAs, and the common symptoms, as already mentioned, are cyanosis and swelling. We deal with them with leg elevation and diuretics. Pain, we use painkiller and occasionally epidural catheter. The distal necrosis, secondary to this ischemic still syndrome that may need debridements if necessary, and an unusual symptom, but sometimes it is present, is the cardiac failure because of this overloading. So you really need to be patient to stand this storm because it takes 6 to 8 weeks to see a clinical improvement with granulation tissue achieve wound healing. And once you pass these 6 to 8 weeks, you need to be really expeditious due to the low patency rates of these procedures and perform in time tension-free amputation. And this is going to be extensively explained by Cristian later on, and have a low threshold for reintervention in case you have any doubt that anything is not going really well. So last word for flow focalization, which is the embolization of the proximal foot vein in order to give flow to the forefoot. And this can be performed on demand in case of insufficient clinical improvement, or systematically as recommended by Roberto Ferresi 2 or 3 weeks later following the procedure. So this is one of our cases with a DVA with initial nice granulation tissue, but 4 weeks later the wound didn't look so well, and then we performed an angio which pointed out that the arterial flow was occluded and there was flow centripetal flow going to the heart. And then it already has been mentioned, we perform a pre-PTA of the artery and coiling with standard coils of the vein collaterals in order to avoid this bleeding of and focalized flow to the forefoot. And several months later, we achieved this complete wound healing. So thank you very much.
Thank you, August. Unfortunately, I could not see your presentation at all. So, okay,
I will transfer it to you.
Okay, but there are many questions. So guys, I don't know how much time we have, but I try to select probably the.
But Marco,
now can you see the question?
We have the last presentation by Cristian, and then.
Okay, of course.
Okay.
Okay. Good afternoon. Do you see my slides?
Yes.
Yeah.
Yes. Okay. Thank you. Thank you very much. Good afternoon, everybody. I'm not a vascular surgeon. I'm not a radiologist, but I am only a poor diabetologist that in the last 20 years of my career deal with patients affected by diabetic foot like this. This is a patient that after an urgent surgical debridement of an acute infection and after a revascularization for a critical limb ischemia, now needs something more and some more work from me to get the wound closure and to heal. And I have to say that the attitude, Marco Manzi started with this item, the attitude of the diabetic foot surgeon like me towards this kind of a patient has completely changed across the last 25 years. In the last century, as you can see here in this picture, the best revascularization item was considered the above the knee vessels. And so as a consequence, our aim was to achieve the healing of the patient as soon as possible. And that's why sometimes we decided to perform a lower extremity amputation, because we told to the patient that this was the best way to get the primary intention closure of the wound and to avoid the typical progressive of the amputation, first then the toes, later the forefoot and so on, that were typical of a diabetic foot disease. And we also told the patient that the best way for him to come back to work as soon as possible was a limb prosthesis. Then little by little we understood that probably this was not the best approach for our patients, and we start to follow this patient for years, and we noticed that compared to patients for whom we were able to achieve a limb salvage, patients undergoing a major leg amputation had an increased risk for death, and also an increased risk for the amputation also of the second leg within 5 years. And so we begin to understand that we had to do something more for these patients. And in this century, thanks to the improvements, the great improvements in revascularization techniques and in technologies, vascular surgeons and interventional radiologists revascularize also below the knee and below the ankle vessels, as you have just seen in the previous talks. And so, as a consequence, our mind has completely changed one more time. Now we take some time to get the healing time for the patient, not too much time. I will show you now why. And so we used to perform the so-called multimodal therapy. In a situation like this, we have a gas gangrene of the foot. After the surgical debridement and after the revascularization, we perform a multimodal therapy made by negative pressure wound therapy with or without instillation of antiseptic. We use the modern techniques of loading using these devices. We use modern reconstructive techniques such as the graft of dermal substitutes and the autologous skin graft until we reach the healing time. And concerning to the timing of this multimodal therapy, we had some data like this coming from the Luigi Uccioli group from Tor Vergata University in Rome, that show us how after a successful PTA, the level of TCPO2 significantly increases for 4 weeks. And so it is better for the surgeon to perform the multimodal therapy not before the 3rd week after the PTA, because here we have the maximum, the peak of the TCPO2 increasing. But on the other hand, we have also data like this coming always from the Luigi Uccioli and Tor Vergata University group that shows us how almost 24% of patients in this casuistic had a recurrence of critical limb ischemia after PTA within a follow-up medium of 1 year, and they need a secondary PTA, and the mean time between the first and the second PTA was in this casuistic 3.5 months. So to simplify a lot, perhaps to simplify too much, I could say that I don't have to treat the patient before 3-4 weeks after the PTA, but I have to heal the foot and the patient before 3 months, because otherwise the risk for the risk for a secondary critical limb ischemia is increasing. And now we arrive nowadays with the DVA. You have just seen the wonderful talks that precede me, and also in this case our mind has completely changed one more time, and so we don't have to be in a hurry. Now I will explain you why. And now we are talking about tension-free surgery, and tension-free surgery is something that has been introduced in the limb salvage field by Roberto Ferraresi in this paper that talked about this waiting strategy that a diabetic foot surgeon should choose to give the venous arterialization time to develop and to let the wound demarcate. And so now it's too early, in my opinion, to draw conclusions and to give statements about this tension-free surgery, but we are making more and more confident with this technique, and so this is my opinion about the cornerstones of tension-free surgery. First of all, we have to try to achieve a secondary intention closure rather than a primary intention wound closure. And if possible, we have to avoid skin sutures, and eventually we can use subcutaneous sutures. But we have to respect, from the anatomical point of view, the new blood flow that is created to the foot. And this is a picture, this is me in my operatory theater during a minor amputation in patient after a DVA. And as you can see, I always take a look to the angiographical pictures, to the angiographical imaging, because I base my tension-free surgery right on the angiographical imaging of the foot. I try to remove the necrotic areas, and I try to preserve the vessels that the vascular surgeon, that in this case was Bruno Migliara, with a lot of effort has restored to the foot. And in this particular field now, we are getting more and more confident with the indocyanine infusion that can help us in choosing which is the part of the foot that has to be removed and which is the part of the foot that we can preserve. Always keeping in mind the biomechanical stability of the foot, because the patient, don't forget that after the DVA and after the tension-free surgery has to walk. And again, the multimodal therapy is still effective. And so one more time, we can take time to heal the patient. We have to choose the best time for the surgical debridement or a minor amputation. And we can help the healing procedures with, for instance, one more time, the autologous skin graft or the dermal substitute graft, just to cover the bone exposure until the healing time. But in my opinion, the most important thing when we deal with tension-free surgery is that the diabetic foot surgeon must not be in a hurry. And I conclude with this picture. Take a look to the starting situation of this foot, the desertic foot with a very low level of TCPO2. And on the right part of the slide, on the top, you see the situation, I think, a couple of days after the DVA, with a good increasing in TCPO2 levels until almost 30 millimeters of mercury. But take a look to what happens 6 weeks after the DVA, with a further increasing in TCPO2 level, almost 50 millimeters of mercury. And for a surgeon like me, it's better to work with 50 millimeters of mercury than with 30 millimeters of mercury. So in my opinion, we have not to be in a hurry after a DVA, and we have to start our surgery not before 5 to 6 weeks. Thank you very much.
Thank you. Very interesting.
Okay, guys, thank you, Cristian. There are a lot of questions. I don't know if you can see the questions and read the question. There are many interesting questions, but there are really a lot. So I try to choose something could be interesting. From Luis Morelli, another click participant and faculties, concerning DVA storm. In order to avoid getting too late, should we monitorize this patient, maybe transoperatively measure velocity with ultrasound to see the need of acute embolization? Should an echocardiogram or cardiac hepatic enzymes should be monitored to avoid or detect acute symptoms of cardiac and hepatic failure that could indicate an acute closure of the fistula or even amputation to save patient life? It's a complex question. About clinical management of the acute changes in the foot. How can we avoid these changes if it's possible? And which are the most interesting symptoms or clinical laboratories we have to check for this patient?
So as you know, with clearly failure distal DVAs, we have quite limited experience with proximal DVAs. And as I've mentioned, the post-DVA storm syndrome is quite limited in distal DVAs because you don't have this shunting. So edema is not really a deal, and definitely heart failure, we have never seen that. This is not a contraindication for a distal DVA, whilst it's a contraindication in most of the trial with proximal DVAs. And in terms of measurements, I'd say that flows below 100 would arise a suspicion that something is not going well in your graph.
Okay.
If I can add something for the follow-up of these patients for the changing in the clinical signs of the foot, as somebody I think August told before, is mandatory a strict follow-up of this patient. We evaluate this patient every week in our ambulatory and in our clinic settings, and every time we perform TCPO2, every time we check, because don't forget that many of them are diabetic patients, so they have an increasing risk for infections, and if a patient like this has an acute infection, we have to bring him immediately in operatory room within 24 hours for the bacterial load control. So this patient requires a very strict follow-up in a clinic setting.
Yeah, definitely. And as we already mentioned, pain is a real issue of these techniques. That's why they should be monitored quite strictly. In the ALPS trial, which is going to be published in August in the Journal of Endovascular Therapy, primary petity is 2.6 months. So that really needs to be taken into account.
May I add something to this? Because actually, this is really something new, but we have live the image of a case performed by Dr. Morelli, who would like to share this with you to understand what actually went wrong. So if you like, I can share with you. This is the image he was having just before an AV fistula performed in the posterior tibial. And actually, I can also share with you right now a video with what we had as a final result in that fistula. The other information I had from Dr. Luis Morelli is that the cover stent has been implanted in the posterior tibial artery, and it was a cover stent 5 millimeter and 5 centimeter. Unfortunately, a patient had an acute dyspnea and heart failure, and I can show you right now also the image at the end of the procedure, which I think was
okay. This is a typical stagnation syndrome.
okay. And would you suggest something to Dr. Luis Morelli?
No, the problem is that the stagnation syndrome can occur is the most serious complication, and also in our experience we had this situation. Usually in the angiography we can see well that the flow arrive well into the foot, but the evacuation way is not so good in the superficial dorsal system is not so good. In some cases, I had this in patient without the great saphenous vein because the evacuation way is not so good. Then there is a venous hypertension in every portion of the foot with a necrosis. And the only solution described also by Mutirangura, by Lengua, this situation is the major amputation with an open arterialization. This is a complication, the most serious complication. On the other hand, the risk of heart failure exists. Of course, now in every patient we perform the study of the heart before with an echocardiography in case of an ejection fraction lower than 40%. We don't perform the arterialization. We stop.
Thank you very much. I think if you like, we have 5 minutes still. If you want to select another question, or if you want to do a round of take-home messages for our audience, as you prefer, Dr. Manzi.
I saw an interesting question. Sorry, for Bruno, about the choice of the veins. Sorry, I selected. Yes. Any suggestion about which of the two posterior tibial veins you have to choose with your pioneer technique?
Well, usually with Pioneer, it's possible to evaluate well this vein and to choose the biggest one. But in
so
some
normally
cases,
the choice is for the biggest.
Yes, I try to choose the biggest one, but in some cases this is not possible due to the calcium, and then I choose the easiest one to punch.
Okay.
Because at the end I place it's only a support for the via band. Then it's not important the diameter. I place 5 millimeter via band into the vein. Then I can also place this outside the vein, but the problem is the entry into the foot. It's only a support.
Okay.
Marco, there is a question on the best pressure for the negative pressure wound therapy in these patients, and a very fast answer: 125 millimeters of mercury for Kinya Matsui.
Okay, perfect. Thank you, Cristian. No, there are a lot of questions, so it's difficult to technically there was questions about the use of Lemaitre valvulotomy, which could be proposed and used instead of stenting. What do you think about this technique? Roberto Ferresi is and Steven, they did. What is your opinion, Bruno?
At the beginning of our experience, I started using valvulotomy. Of course, on market doesn't exist the reversed valvulotomy because it's only in the lymph flow kit. Then I use the full French Andromed valvulotomy. If you go forward and backward, it's possible to remove valve. But now I stopped to use this because into the foot, usually with an adequate venoplasty, usually 4-5 millimeter dilatation into the deep foot vein and 3.5 into the dorsal main vein of the first two is enough to crash the valve. Eventually, to crash this valve, usually I inflate the balloon to 10 atmosphere, and then I deflate a little bit and try to strip the balloon to crash the valve. I don't know if it's a good idea, but works. And then usually in the last patient, I never used the valvulotomy. I stopped to use the valvulotomy. I don't know, August, what is...
Well, I think we should remember that for proximal DVAs, the role of the cover graft is not only to deal with valves, but also to avoid bleeding of collaterals. So you need to focalize flow. With regards to distal DVAs, we actually use plain balloon angioplasty, and as Bruno mentioned, in case of residual valve stenosis, we use a cutting balloon in a surgical way with halfway inflated and then retrieve it, last common valvulotomy. Yeah, and it works. Actually, valves from the ankle to the toe are not really a huge issue.
Okay.
No, I had only the problem in case of an hybrid arterialization, because at the level of the marginal main vein of the foot, because it's below the the skin. In this case, with a balloon venoplasty, is in my hand, it's impossible to crash valves. Then in this place, I use the valvulotomy in case of an hybrid DVA. But in the plantar, in deep plantar vein with the venoplasty, I think is enough.
Okay, so guys, the message, I can try to summarize some messages for me too. This is an ongoing experience for everybody of us, I think, and probably a good hope for our worst patient as we experience. So it's not only an issue, not only a problem to create the fistula, the communication, but this communication must be supported by first anatomical situation. We have to know what is going to happen, choosing the site for this fistula. So physiopathological, we have to understand what is going to change for that patient and the possible complication that could be severe, as Bruno showed us, and as Miguel Montero Beger described in a comment in this session. Second, we have to maintain the fistula, we have to maintain the flow, which means an aggressive follow-up, an aggressive maintenance, even with re-angio the patient and close the collaterals, ligate collaterals. Aggressive surgery, but with no hurry, as Cristian showed. So modification in the timing for this patient. Of course, we have to exclude for this procedure patient with active infection, I think, and probably we do not have to wait desperate situation to shift to this kind of procedure. I don't know if you agree. Probably we have to move in an early stage when we understand that any conventional attempt will be a failure. What else? Techniques are very, very different techniques to achieve the fistula. So technical tips, but the final purpose is to achieve a nice pressurized flow towards the wound. There was a question. We showed the most of patient, the most of imaging we showed demonstrate a transmetatarsal, so a forefoot amputation decision for this patient. And the question was why the most of this patient underwent to a transmetatarsal amputation compared to the last patient. Cristian showed us only two toes amputation. This fact is because it's difficult to have a perfusion into the toes, or because it's safer for the patient to receive a transmetatarsal amputation.
In our experience, of course, we started with the worst patient, and then this is the reason why we started at the beginning with 2 necrotic, and then the TMA is the choice. Now we shift a little bit with patient with less lesion, and then I think the problem is not due to the absence of the flow into the forefoot, because now we can obtain this this flow, but of course a little bit of we lost a little bit of tissue when we perform p-DVA and we compare this with a normal PTA. I think, I don't know, Cristian, if he's agree with this, but I think this is our situation now.
I agree, and it's important to think further, because it's true, we have to save the limb. First of all, we have to save the life of the patient. Second, we have to save the limb. Third, if possible, we have to save the foot. Fourth, we have to think from a biomechanical point of view that this patient has to come back to work. So from this point of view, both the transmetatarsal amputations and the amputation of some toes or some ray are effective from the biomechanical point of view, and this is important. It's useless to save a foot that can be loaded during the walking.
Yeah.
I don't know how much time do we have for this session. I think that
Sergio.
Dr. Manzi, if I leave you alone, you will go on for hours.
yes, I
So,
know,
actually,
I know.
And actually, with more than 50 questions, we can either decide to stay here another couple of hours or to write a book. So probably I will collect all the questions, send them to you, and then we create, the manual of the DVA. No, just kidding. But for our audience also, if you have some question you want to add, we can forward them to our panel and try, with the correct timing to give an answer to everybody. At the end, if you agree with me, I will close the session, even though actually the attendees are all still with us. This is something incredible after 1 hour and a half almost of presentation, but it perfectly describes the interest behind this technique. So thank you very much again for having made it this possible, and yeah, thank you very much again for attending. Word to you to greet our audience.
Bye.
Thank you, Sergio.
Wow.
Thank you,
Thank you,
guys.
everybody. Thank you.
Thank you to everybody.
Thank you.